giving you a usual weekly update on COVID-19 in our community, and also talking a bit about all the usual things, testing, kind of where we're going to be going over the next few months or so. A little bit about some of the research that's been going on with regards to vaccine testing, safety, and efficacy, and just review kind of what we've been over the past few weeks or so. So starting off, we've had about 62 active cases right now in the community. One of the numbers that we always talk about is the positivity rate, and there's two different positivity rates that we talk about. One is the unique individuals positivity rate, which ours is around 18% for our county, and then the all individuals positivity rate, which is around 5%. And we keep looking at that every few weeks or so, really specifically to look at what that trend has been, and that's really the most important thing looking over the past few weeks or so.
Yeah, and what we have seen is that the volatility of that can be pretty significant based off of those county numbers, and as testing increases or decreases on a weekly basis, that 7-day trend can have an impact. But the 18% for unique individuals remains a pretty high number, so really reinforces that our social distancing, our wearing of masks, our hand hygiene, monitoring your own symptoms, decreasing travel from traffic to grocery stores and other stores. Certainly, if you need to get out and take care of those activities, do so, but have a plan for that, and minimize maybe the number of individuals in your family that are getting out and making those trips, and indoor versus outdoor activities as well. Reinforcing that outdoor activities are certainly recommended during this time. But that 18% remains pretty high, and we want to see that down. Ideally below 10% would be where we would want to see that go. Unique versus all tests. So unique is individual patients being tested, whereas all tests can include one individual that's been tested multiple times. So that's the difference in how that data is reported.
And we tend to look at that unique individual a little bit more closely, because there are a lot of institutions, there are a lot of facilities and nursing homes and hospitals and things like that that are having people tested weekly or every few weeks or every few days. And that tends to skew that number, because some individual may be tested 10, 15, 20 times over the course of the last few months. So the unique individual is probably the most important number that we look at. Now, one interesting trend that we look at is we get to look at our district and then also at our state in terms of what numbers are doing. And when we look really at the whole state, numbers are coming down, and that's very encouraging. We spoke a little bit last week about our neighboring states or our neighboring counties that were a little bit higher. Those numbers are coming down as well. And we're sort of holding our breath, because we're in that post-holiday period where we anticipated we would see numbers go up. Now, thankfully, one of the things that you and I have been closely involved with is the schools and what's happening in schools as far as positivity. And the good news is those numbers have been looking good.
Yeah, they've really done a great job in our meetings with them. And overall, faculty, student numbers have been low, have not had to move in the direction of a virtual learning environment, which we are very thankful for, not only for ourselves because we have school-age children that can go to school, but for the community as well. And that learning environment is really supported in that on-site ability to provide that atmosphere. So that's very, very positive.
The other thing that we talk about every week is testing and testing sites and what type of testing that we're doing. One of the shifts that we'll see this week is to split apart on an age basis who gets the standard posterior pharyngeal testing, nasopharyngeal testing, and who gets anterior nares testing.
Right.
And we talked a little bit about that last week. You want to speak a little bit as to where that will happen and how we're breaking that up?
So still our two main testing sites, Convenient Care out at the Willow Plaza and MCV, the Medical Center of Vincennes, both have testing sites. What that shift is that 12 and under will receive a anterior nares type of swab. So the test itself on the background, the reagents, the identification of the virus is all the same. Same specificity, sensitivity that we've talked about in the past. If the virus is present, we will detect it. It's a matter of how that collection occurs. So the anterior nares is swabbing of the inside of the nostrils, whereas if you are over the age of 12, the gold standard and recommended practice is the longer swab, the nasopharyngeal, that gets to the back of the throat up through the the nose. For inpatients, anyone coming into the hospital, that will remain the nasopharyngeal swabbing. But in that ambulatory setting, convenient care and MCV, what will happen there is it will be age-based as to how that collection will be done.
And there a lot of questions come in every week with regards to the other types of testing, one of them being salivary testing. And really the reason that we're sticking with these two modalities of testing is because they tend to be the most accurate.
Right.
There's all kinds of questions about false positivity and false negativity, and when we look at all of those statistics, these two methods of testing are the best that we have out there. And as Adam said, kind of what we're considering the gold standard or the best tests that we can do. As that evolves and more data and statistics come in, we may look at some of those other modalities, but as of right now, those are still our two best ways to test.
And we are actively looking at those today. Our lab reviews as new tests get FDA what's called emergency use authorization approval. Saliva and antigen testing are the two that are really out there that provide that point of care rapid result. But the counter to that is you get this rapid result, but is it accurate?
Right.
And so our approach has been we're going to stick with as accurate as possible, even with that 48 to 72 hour lead time. As those tests continue to develop, we'll stay on top of that, and ideally it does move in that direction, and we have a point of care rapid test that is very accurate and can give us the same level of confidence in the results that we received today through the swab test that we're speaking about.
The other thing that we've spoken about each week is what to do if you develop symptoms, and it really varies tremendously upon what type of symptoms you have. Obviously, we're in the middle of allergy season now, and so we see lots of runny nose and cough and congestion, things like that. And those symptoms can overlap to some extent with what we see with COVID-19 and also with some respiratory flu, which incidentally we had a reported case of last week as well.
Right.
So we want to be on the alert for these things, and the most important thing is to get in contact with your providers or our triage line to discuss what your symptoms are, how those symptoms came on, and then how sick you are at this point in time. We then kind of go through an algorithm ourselves to either evaluate you, do a virtual visit, or determine what type of testing needs to be done. It's been interesting. We've seen a lower number of childhood illnesses this year than we have in years past, primarily because of the precautions that we're taking for COVID-19. But we certainly anticipate as we go over the course of the next few months or so and we enter into cold and flu season that we will start to see other respiratory viruses come to the surface, and we will see more of them happening. And so there will be some overlap that goes along with that with COVID-19. The other thing we spoke a bit about last week was the studies that are being performed in the Warp Speed trials as far as getting the vaccine out. One of the trials had been held because of a potential problem, and that trial has been resumed. And so we're encouraged to know that that's proceeding, and that as an organization, as a county, we've been instructed to really be prepared for vaccine distribution in the near future.
Right. By the end of October, actually, is what the CDC put out as far as being prepared, or HHS, I'm sorry. So with that, we have, I believe, 8 vaccines that are going through that process and that warp speed. And we always get the question, we're moving so fast, is this safe? But the speed at which we're moving, the resources that have been added to be able to move at that speed really are in equivalent to what would take 7 years is being done in a number of months. Now, this will be a phased-based approach to vaccination, so it won't be everybody, if it's available on November 1st, everybody is vaccinated by November 2nd. It will be phased based off of the population that is at highest of risk, healthcare workers, and then moves down to your younger, healthier population. But as Dr. Stine mentioned, one of the trials was halted due to a safety review. I think if you looked that up, what's interesting is there were a number of clinical researchers, physicians that commented, this is common. This happens with every vaccine, with every drug. There is almost always a pause. Should we move forward? There's those decision points. You just never hear about it because it happens over 7 years, and really nothing in our lifetimes has ever had the scrutiny that a COVID vaccine and treatment plan has before.
And as Adam had mentioned, as we go into this and there'll be this phased release, it's important to be in contact with your provider, especially if you have any of the conditions that we are concerned about being a predisposing risk factor for COVID-19. So if you have chronic respiratory problems, COPD, emphysema, have had pneumonia frequently in the past, or bronchitis, you should be in an early group to get vaccinated. If you have a compromised immune system for any reason because of treatment for other diseases, cancer, immunosuppression for autoimmune diseases, you should be in the early groups to get vaccinated for that. We are already communicating with our patients that we see on a serial basis to make sure that they're aware that when that becomes available, they should be in the early groups. The other thing that is super important right now is getting out and getting your flu vaccine. Flu vaccines have been coming into nearly all the facilities, including our own, our surrounding health departments, including the local pharmacies that vaccinate. And we want everybody to get out and get their flu vaccine. This is so important, and important that you get the right flu vaccine. Most of us will receive standard flu vaccine. The population over 65 should receive the high-dose flu vaccine, and those vaccines are now available in nearly all of those type facilities. So we would really encourage people to get out and get their flu vaccine now. There is no such thing as too early. That has been clearly proven in studies to show that even though you might have heard over the past 20 years or so, oh, don't get your flu vaccine too early, it'll wear off. That is certainly not the case. So we encourage everybody to go out and get their flu vaccine now. That way our population that is at risk for that will be lower risk. And then also to make sure that we don't see that overlap that will occur with flu symptoms looking and sounding a lot like the COVID-19.
Right. October 14th through the 20th, we will be offering drive-through community flu clinics. There will be more information coming out on the specific dates as far as the evening hours, the Saturday hours that we will be providing. And I think a lot of every year there's the conversation of how effective is the flu vaccine, and that remains to be seen because as we vaccinate individuals and see how effective it is on what strains are being picked up this year, more of that information will come out. But one thing that remains true is that if you get the flu vaccine, if you do contract the flu, you are likely to have a lesser acute event from the flu. So even though the flu vaccine it's not 100% foolproof, you won't get the flu. In doing so, your illness will be lessened, which is important as well.
Absolutely. One of the things that we also talk about each week is visitation policies and kind of where the hospital is with that. That's something that we have had to look at on a nearly weekly basis, depending upon how high the incidence of disease has been in our community. Would you give us a little update on where we are with those policies?
Yeah, it continues to evolve, and community transmission, which is what that positivity rate tells us, plays a big role in what visitation looks like. So CDC recommendations that we follow very, very closely still recommend decreasing traffic in healthcare facilities because of potential asymptomatic spread. The jury's still out on what exactly that looks like, but even minimal symptoms may be shedding virus and can spread. So our visitor policy is that for visitation on the inpatient side, we're allowing one visitor. Through our inpatient floors. Our surgery areas allow a visitor. In our medical offices can have a visitor. Certainly want the family involved to be able to help with the clinical decision making of what care is being delivered. And then there are some exceptions on the inpatient side, end of life, if patients have a difficulty making decisions, maybe due to mental capacity or what's going on with their care, and being able to have a loved one there to help with the decision making. I think as we've seen that increased community transmission and we've seen increased admissions to the hospital for COVID patients, we've had to specifically look at what does that look like? What does visitation look like for a COVID patient? And keeping in mind that it's a balance of safety and the family being able to be there with the patient, because that transmission, while we wear PPE, the masks, the goggles, the gowns, there still is a inherent risk to that we are allowing somebody to take. So for COVID patients, and unfortunately we have had some deaths, so for COVID patients that are at end of life, they can have visitors that follow our end of life visitation policy. For COVID patients that are stable or recovering, being provided care, you will get an update from a medical provider daily to the designated care provider, I think it's important that everyone understands that we can't communicate to a large family of 10 and call each family individual, but every patient should have a medical representative, designated care provider, the terms that you may hear, and we communicate daily from our medical provider team to that individual regarding the patient's care. And then if there are any change of status, let's say that somebody's on a general medical floor and they need to go to ICU for a higher level of care, that would automatically be a communication point. Or if there's a change in treatment plan, you've heard about, let's say, remdesivir. So we're going to try a investigational drug for COVID. Those would also be communications, and especially in any case where the patient is struggling to make their own medical decisions due to the level of care that they're needing. All of that will be ongoing communication. It's a fluid environment. It can be difficult because our care team's first and foremost responsibility is to take care of the patients in front of them. But that communication plan is continuing to evolve and be improved upon, and that's something that our nursing team, our medical physician teams takes very seriously.
And it's very important, too, to look at who the individuals will be that will be visiting the patient. It's in some of the cases I've been working with over the course of the past several weeks, it may not necessarily be the spouse that is bedside with the patient. It may be a younger family member because we want to help families understand what risk they're accepting by being in with that ill family member as well. And then, as Adam said, one of the most important things is having that designated person to communicate with. In the patients that we've had in the hospital over the past several weeks, there has been communication primarily just with that one individual, and then it's their responsibility to disperse that throughout the family. That's really the way that we do it even outside of COVID. When we
Right.
look at any time that we have patients that are in an intensive setting, either in the ICU level 1 or 2, who are ill, we want to make sure that there is clear communication between the healthcare team and then that one individual of the family who can disperse that throughout the care. As a family physician, I kind of act as the outpatient liaison for that to help them understand what's going on, but it's important to realize that that one individual will receive that communication and then distribute that throughout the family. Any other issues before we go to the phones?
I don't believe so. Let's see what questions we have.
What do you have, Tiffany?
Okay, there are several questions regarding a comment that was made by Dr. Stewart in the Sun commercial on Saturday about the number of vent patients, COVID patients, and only one patient coming off of a vent. Can you guys explain that comment?
Sure. Yeah. So as we have seen from the beginning, so go back to March, that the recommendations around mechanical ventilation for COVID patients have continued to change. Early on, it was a mechanical ventilation early, and then as that had progressed, the outcomes simply weren't there, which means patients were expiring, not at Good Samaritan at that time, but as we move forward, it's to ventilate later and hold that off as I won't say an end of life, but as a last element of treatment. So patients going on the mechanical ventilator are severely ill. A lot of times they are progressing to a point that they may not be able to recover from. So we have seen a number of our deaths have been on vents. I think when you look at the national numbers, and I looked at them this morning because I had seen that comment as well, the mortality rate is up to about 60% on patients that go onto a ventilator. So that would mean 6 out of 10 patients nationally are not coming off of the ventilator but are expiring and unfortunately are dying. So that's something that we're continuing to look at. As far as our own internal data, we don't share patient-specific information, but we are continuing to look at that. I think the commentary, though, is that patients, or my response, though, is that patients with COVID that are ending up on a vent are acutely sick, and that is towards the end of the, I guess I will say, the medical decisions that can be made. We've tried all other options, and now they need support and breathing on their own. And the population that are going onto those ventilators are older population that are potentially have some of those high-risk conditions, whether that be heart disease, lung disease, and coming off of the vent. If they had a different viral infection, the outcomes would be very similar. So this is not just a COVID impact in what we've seen thus far.
Yeah, and this has everything to do with what we've talked about all along, which is stratifying that population and being extra cautious if you have greater risk factors. As Adam said, one of the things that we see, unfortunately, every day is patients who have chronic medical illnesses, whether they're involved in a car accident, whether they get pneumonia, whether they have emergency surgery for something. That population is much, much higher risk as far as having needs for being ventilated and then not being able to come off of the ventilator. So it's not just unique to COVID-19, but it's important to realize that that population is what we are seeing. Now, we've been very fortunate up until the last few weeks that the number of inpatients that we've had have been very low.
Right.
The number of patients who've required mechanical ventilation has been very low. And for everybody else out there who's concerned about numbers and availability of services, we still have tremendous capacity locally and then also within our region for ventilators. That's something that very early on was a tremendous concern. The number of ventilator production was ramped up exponentially, and so nationwide, statewide, district-wide, and then regionally, that's not a problem. But the issue really is the pre-existing conditions of a lot of patients that are contracting this now.
There's a couple of other questions, back to the communication. So I guess there is a family that's saying that they've gone 30 hours without communication. So what does a family do at that point if they're not receiving communication like they should be?
Sure. So two parts to that question. So the first part is I'm aware of that situation, and we were having meetings this morning. There is a communication plan in place. That family in particular is being contacted or may have already been. As such, we've been on this the Facebook. So as far as if you're not receiving communication, I think there was a perception put out there of do not call. And if a loved one wants information or a caregiver wants information on their family member, they can call the nursing supervisor, call through the hospital switchboard and either talk to nursing supervisor, or they can talk to the floor and get the nurse or the care team that is taking care of the patient. What we're encouraging is that with those daily updates, with the ongoing proactive nursing communication, that a number of people calling at the same time is going to pull our team away from being able to care for the patients that are in front of them. So we ask that there's not hourly calls, consistent calls, but if you're not getting communication, then call the hospital, ask for the nursing floor to speak to somebody taking care of the patient. If that doesn't work, which it should, if that doesn't work, then ask for the nursing supervisor, and then they can help you as well. If they don't have the information or there's another individual that's more appropriate to speak to, they'll help to coordinate where that call should go. But that is being looked at. I mentioned that our communication plan is fluid and such. Really, end of last week, put in a more robust communication plan. Through the weekend, there's certainly some opportunities to work through that further. But our medical residents, our hospitalist team, that are medical providers taking care of the patients, are going to be communicating at a minimum daily on what's going on with individual patients, and then the nursing team will add to that as far as any status changes or those determinations, decision points that need to be made.
Okay, and to add to that, I have a message from our chief nursing officer. She said to make sure that the family that is calling in is the designated family member that is to receive that communication.
Yeah, and we mentioned that just talking about the visitation. That's a really key point, especially larger families. There's that medical representative, that designated care provider. It's important that we're communicating to that individual. They've been deemed that authorized person that we can share, not only from a HIPAA standpoint and privacy, sharing that information, but it also is we have to have one point of contact, and then that individual has the responsibility to communicate to the rest of the family, which I know can be difficult, and there's family dynamics that come into every element of this, but making sure that that individual is communicating out to the rest of the family. Because if you step back and it's very personal when it's your loved one in the bed in the hospital, and we certainly understand that. But if you step back and understand that our team can't communicate to every family member the same information 4, 5, 10 times, but have to have a point of contact so that their time has to be spent, most importantly, at the bedside taking care of patients.
And then another question is regarding the vaccine for COVID. Would we have multiple sites to get the vaccine? And maybe even tell them a little bit about the drill that we're doing here for employees.
Yeah, so I mentioned October 14th through 20th is our drive-through community flu vaccine. On the 13th, we're actually doing a mass vaccination drill, which will be for our employees here, where our goal is to vaccinate 1,000 plus employees in one day. So why are we doing that? Very different than how we have administered flu vaccine in the past to our healthcare team, which is a mandatory annual event, is to plan for what the vaccination plans for a COVID vaccine would look like. One thing that is going to be a big determining factor is what the vaccine looks like.
Yep.
So what we expect is that the COVID vaccine will actually be 2 injections, so 2 shots that are 21 to 28 days apart. That changes things pretty dramatically from what the flu vaccine is. We also expect that when you get the vaccine that there will be a direct monitoring piece of you have to be monitored by that healthcare provider that gave you the shot for 15 to 20 minutes. That also changes things. But we are working through exactly what that will look like, and part of our influenza vaccination plan this year is to prepare us for what a COVID vaccine rollout will look like. But ultimately, there are some questions that we simply can't answer today, because when the vaccine gets approved, it will get approved with a what's called a vaccine information sheet, as well as a national pandemic plan that will say this is how the administration should occur.
And that plan initially will be one site, but as the kind of you were asking there, Tiffany, there may be multiple sites that come out. No different than as we started out with a single testing site. We've expanded that to 2 sites based on volume. The same thing may be the case when we get to vaccination, depending upon what that volume is. As Adam was saying, based on how the vaccine comes, how it needs to be administered, and what that monitoring is, how that traffic flow will happen either here at the hospital or at remote sites is all going to be tremendously dependent upon that. So main thing is to make sure that how it's administered is safe, making sure the monitoring afterwards is safe and appropriate, and then how we bring those patients back at whatever interval it's going to be.
The other, whether it's one site or multiple sites, will be what the final definitions of those phases are. Mm-hmm. So who's in phase 1? If it's healthcare workers, that we kind of control that here and are able to provide those sites on site. If it's healthcare workers and community members that are at high risk, we may have to add additional sites. So that will be a big determining factor as to what the number of individuals needing vaccinated in phase 1 is versus the 1 through 4 approach.
Okay. That's all I have for you.
Thank you. Well, everybody, please stay vigilant. Do your good, normal hand hygiene. Be cautious about social distancing. As Adam alluded to, it's always better to be outside than inside, and this is a spectacular time of year to be outside for sports and other activities. And wear your masks. We fully anticipate that as we get post-holiday here, we see our peak, we see things come back down. We want to continue to be vigilant about that and use the precautions that we know that will help us get us through this. We'll be with you again in a week. Thank you very much for joining us.